Thank you very much. I believe we had the most elegant meeting room, the members' room, and I learned that when ICH meets, they typically meet in windowless offices and rooms. So we had windows. It was a terrific group with representation on the part of regulators, PAHO, industry, consultant, and quite a bit of breadth and depth of expertise, ably led by Amrit Ray, for the record. And I'm going to take a top four approach to sharing with you the key findings from our deliberations. Beginning with gaps. So we also began with gaps, as we were instructed to do. And what was rather interesting is the group spent a lot of time identifying that the need for strengthening capacity around post-marketing safety surveillance. That was the focus of our group. So strengthening capacity before harmonization and convergence. What drove this is an acknowledgement on the part of the group that there's quite a bit of variability in capacity as well as in performance in the area of post-marketing safety surveillance when you look across the globe. And that although it's important to strengthen, it's particularly important to strengthen it with convergence and harmonization in mind, because to do so prospectively is a lot easier than doing it retrospectively. And along that line, bringing more countries into ICH was also brought up as a related area of gap. Number two was variability in safety reporting between countries. In other words, there were variabilities noted in the individual case safety reports, as well as periodic safety update reports. Even small differences between countries create headaches, particularly for those who need to complete them and adhere to regulations. Elapsed times necessary for reporting and PSURs was flagged, as well as the question and the gap of how do you report from pharmacoepidemiology studies. So when there's a need for a confirmatory study of some nature, there's little understanding of the harmonization of guidance around not only reporting that, but how do you use that information. And so two regulatory agencies might look at the same information and come to very different conclusions on that and lead to variations in time on regulatory action based on safety information. Number three, benefit risk frameworks vary. That was flagged as a gap or are non-existent in some settings. And number four, scope of surveillance. It's the traditional domain of post-marketing safety surveillance has been that of adverse drug reactions, euphemistically referred to as pharmacovigilance, but the group made a lot of effort to call attention to the need to broaden the perspective to also include how medicines are used, as well as product defects, that is falsified and substandard products. So those are the four gaps. As far as the impact, I can go very quickly through this. Wasted resources, which also has an adverse effect on innovation and access. Impact on patients, the potential for greater morbidity and mortality as a result of the absence of good regulatory practices and functional systems for post-market surveillance. Erosion of trust, threats to public health programs and to the use of medical products. And four, which is kind of interesting, the risk of sustaining non-evidence-based regulatory practices. There's a risk there. And also there's a risk of adopting new approaches that might potentially lack incremental benefits. So this was all raised along with the need for evaluation and metrics. Finally, on to solutions. One solution that was promoted and was of high concurrence within the group was the need for a high-level participatory dialogue on a conceptual framework for post-market surveillance. In other words, define the principles of what is the scope and bring in more perspectives than adverse drug reactions per se, but also take into account usage of products as well as product quality. Number 2 for solution is greater transparency. Building confidence among regulators is key to sharing information. We heard more about the PAHO platform, for example, and the importance of sharing best practices as well as exposing weaknesses in a proper manner. Number 3 is incorporating these discussions into trade, and that has worked, and there are clear aspects of healthcare systems strengthening that are very relevant to trade and economy. 4, low and middle income countries can leapfrog with respect to systems and go on to things like mobile technologies for safety reporting. And this is an opportunity for countries to think about this and to develop and strengthen systems and share what works well. And finally, sustain what is already working, and harmonization was brought up. And with that, I'm going to turn the microphone over to you, Tom.
Again, we have a, well, first of all, thank you for a very comprehensive and nicely structured report back. Are there any questions of clarification, other questions on gaps in harmonization in that area? If you could just head to the microphone and introduce yourself with your question.
You may have covered this in the post-market and safety surveillance, but in certain jurisdictions there's clearly a cultural issue about reporting, and we know in certain geographies that physicians just don't report adverse events when we compare them to other geographies. And I wondered if you considered a kind of medical education and training aspect on a global basis.
Yeah, and could you just say your introduce yourself?
Alan Morrison from Amgen.
Yeah, thank you, Alan. And it could well have come up in my 7 pages of notes, but we were trying very hard to synthesize it down to 4 pages. But I made a notation of that. Pre-service education as well as education of healthcare providers around these issues, and facilitating the reporting as well as the prevention, identification, detection of adverse events. Critically important. Thank you.
Okay, thank you.
Great. Thanks, Sandy. And then I'll last turn it over to Diane, who has the unenviable task of covering or reporting back last in a session that has a lot of ground to cover. So thank you, Diane, for doing that.